All right, sorry for the interruption now. Or sometimes you can present with bowel perforation. The patient be very sick, abdominal pains, might have a hole in the colon, okay, or the rectum, and that causes feces and pus in the abdomen. Now, how would you find out whether you have this cancer or not? Well, the easiest test is to go to your GP or to your specialist and ask for a stool or occult blood test. Now, this test works on the assumption that a small polyp or even a cancer causes a minute amount of bleeding, and the aim is to find that bleeding. It's just like a uric pregnancy test, but it's actually testing your stool for any amount of blood. Now, if it is positive, then you need to do a colonoscopy. Now, colonoscopies are probably is the gold standard of trying to detect colorectal cancers. What it does is involves putting a scope, the camera, into the anus and all the way into the colon, reaching the appendix. Now, this is just an illustration of what it's like. So we will put a scope. You enter in the colon, you go all the way to the right side of the appendix, okay, and you might go and just have a peek into the small intestine. And if you find anything like this, if you find a polyp or if you find a growth, we can remove it if it's small, or if it's big, then we'll just take a biopsy, at least we know what it is. And if it's a cancer, then we will treat it accordingly. Right? And if it is a cancer, then it's important to know what stage it is, and patients will generally get a CT. Now, how will you treat colorectal cancer? Well, the mainstay of colorectal cancer is surgery, right? And we know that the colon is supplied by a very rich blood supply, and this blood supply and lymph nodes follow this blood supply. So the aim is to remove the colon, the tumor, the part of the colon which has a tumor, together with the lymph nodes and the blood supply. So if you remove the right side of the colon, it's called a right hemicolectomy. If you remove the left side of the colon, it's called a left hemicolectomy. And if you remove part of the rectum, it's called anterior resection. Okay, now you're talking about surgeries. There are a lot of types of surgeries there. There's the traditional way is called the open surgery, where the patient will have a big cut on the abdomen. Okay, this is how it might look like. Recovery is late, it's very painful after surgery, but nevertheless, it removes the cancer. Nowadays, we do keyhole surgery, which is much faster, less, it's called minimally invasive surgery. It causes less pain, less scars for the patient. Generally, what we do is we put little holes into the abdomen, and we will operate and remove the cancer, just like in an open surgery, but with much smaller scars, faster recovery. Now, when we operate the rectum, especially the male rectum, is as small as a Coca-Cola can. And the challenge is to remove the tumor out from here, and it's not as easy as it seems. So that is why there are emerging technologies out there, like robotic surgeries. What robotic surgery does is that it actually helps the surgeon remove the tumor in very tight, small places, especially if you have a very big tumor. It's not easy. Now, the robot exactly doesn't do the surgery by himself. The surgeon actually controls the robot next to the patient, or he could be in another room, or sometimes even in another state of country. All right? And sometimes we can remove the cancers from the anus itself, which is very low down and very small. Now, obviously, if the patient has developed colorectal cancer and is stage 3 or 4, he needs chemotherapy. There will be another speaker after me talking about that more. And also radiotherapy is for rectal cancer. Now, having said that, there is no place in the treatment of any cancers, especially colorectal cancers, for these guys. All right? So avoid going to the BOMO, because I have seen patients who have delayed treatment because they want to go and see their sensei or their BOMO, and they end up coming much later. All right? Now, what is the screening recommendations therefore? Now, if you're less than 50, you are at low risk. You don't need any screening unless you have a family member who has colorectal cancer. Now, once you reach the age of 50 and above, you are considered at rich risk, and means that even though you have no symptoms, you need to be screened. You need to undergo a colonoscopy once every 10 years, or if you don't want to do colonoscopy, do a stool blood test every year. However, if you have a family history, or if you have some symptoms, you've got to get yourself scoped every 5 to 10 years, all right, and as soon as you can. So what is the take-home message that I would like to give in my talk today. Number one is that the incidence of colorectal cancer is high in Malaysia. It is number one cancer in men, all right, second in women. And unfortunately, because of the awareness and because of the lack of a national screening program, 2/3 of our colorectal cancers present late. And therefore, we have to be aware, and whenever we see a doctor, we actually would probably ask him to help us, refer us to a consultant, or at least do a stool blood test, because screening actually saves lives. Knowing the symptoms early is important, and once, in the unfortunate event that you do develop cancer, the mainstay of treatment is surgery. Right? So thank you very much. You can read. There is, you can Google up this the article on health tips on Telemi. We prepared a pretty good rundown on the disease. And if you have any questions, you can ask us now, or you can contact me. This is my details. Thank you. Thank you very much. Now, there is a question here on whether does removing benign polyps before they turn into a precancerous state completely prevents a person from getting colorectal cancer? Well, as I said earlier in my talk, of course. Now, the thing is that we don't know whether a polyp is benign or not, whether it's benign or malignant until you remove it. And if it is a pre-malignant lesion, you will obviously save the patient's life, because if you leave it or you don't detect it, then in 5 to 10 years, this particular polyp could become cancer. So screening does save lives. Now, will the polyp grow back after removing them? That's the next question. Well, it depends on the kind of polyp. And in the report, whoever removes the polyp, whether it's a surgeon or the gastroenterologist, we have to check on the report on whether the margins are involved. If the margins are involved, then you probably would have to repeat the scope to take a wider margin, repeat the biopsy, or you might even have to remove that part of the colon if the margins are involved, and if the pathology is dangerous. All right. Thank you very much.
Thank you, Dr. Lokman, for the insightful discussions for this morning to kickstart our Saturday. So next, we're going to have Dr. Vijayan, an internal medicine specialist, to speak about tobacco-related cancer. So we'll be back in 5 minutes, so stay tuned on our live sessions. Thank you.